Good afternoon, everyone, and welcome to today's webinar on endometriosis and fertility with Dr. Carleigh Nesbit from Boston IVF. Before we get started, I would like to go over a few quick items. All physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed by Harvard to the address you RSVP'd with around July or August. Additionally, we encourage you to submit questions to Dr. Nesbit using the quick Q&A box. You may send your questions at any time during the presentation. We will address them at the end of today's presentation. I would like to introduce today's speaker. Dr. Carleigh Nesbit completed her undergrad at the University of Virginia. She then completed her medical training at the University of New England College of Osteopathic Medicine, her residency at Dartmouth-Hitchcock Medical Center, and her fellowship in reproductive endocrinology and infertility at the University of Vermont Medical Center. Carleigh is passionate about providing patient-centered fertility and preconception care, and her research interests include genetic screening and reproductive aging. Dr. Nesbit practices at Boston IVF's Bedford, New Hampshire office. Okay, let's get started and take it away, Dr. Nesbit.
Okay, great. Well, thank you so much for inviting me to talk about this topic. I think it's a really interesting one, and I feel like really confusing with the literature that's out there. So I'm hoping we can shed some light on it and generate some interesting questions and discussion. So we're going to be talking about surgical management of endometriosis-related infertility. So let's see, how do I advance? Oh, here we go. I don't have any disclosures. So our learning objectives today are going to be to understand the pathophysiology behind endometriosis-related infertility, as well as review the role for surgical intervention in management of patients with infertility and endometriosis, and then also discuss the role for fertility preservation in patients with endometriosis. So just a little bit of background, I think most of us are familiar with this, that compared to the general population, patients with infertility are more likely to have endometriosis, and patients with endometriosis are more likely to have infertility. But interestingly, we haven't established a direct causal relationship definitively yet. But we definitely have a lot of thoughts of like why endometriosis might cause infertility. And the first thing is that endometriosis, especially in its severe forms, can cause really distorted pelvic anatomy. And I think we've all gone in with a laparoscope and seen a pelvis that looks like this. And it's hard to imagine that somebody can ovulate normally and have normal pickup of the oocyte from the fallopian tube and transport through the tube when their pelvis looks like this. So we think a big part of it is just challenges with the pelvic anatomy that's so critical for getting pregnant. Also, these women are more likely to have had surgery or need surgery, and there are challenges with fertility that come with that, including worsening or new adhesive disease, losing adnexal structures or injuring adnexal structures. And then also anytime we're doing surgery on the ovaries, we risk an accelerated loss of oocytes. But endometriosis is really sneaky and kind of has effects, we think, at a microscopic level as well. So women with endometriosis have been seen to have higher concentrations of inflammatory mediators in the peritoneal fluid. They've actually been seen in the endometrium to have higher levels of immunoglobulins and lymphocytes. They've been seen also in the endometrium to have decreased expression of integrins and L-selectin, which are important for implantation. They've been seen to have a higher rate of impaired dynamics of follicle growth and ovulation. And then they've also been seen to have lower egg and embryo quality. So we see that embryos from women with endometriosis tend to develop more slowly, and actually donor eggs from patients with endometriosis have been seen to result in lower quality embryos, and these embryos have been seen to have lower implantation rates. So another thing is endometriosis can cause functional infertility. So this is a speculum view of a cervix and sort of a rare vaginal presentation of endometriosis, but you get the point that, if you're in pain, or you're not feeling well, or you're having other bothersome symptoms, it's really hard to want to try to have sex around the time that you're ovulating to try to become pregnant. So there's a lot of factors that are contributing to these women having a harder time conceiving. Endometriomas as a distinct entity can also impact fertility. And we think that, that's because of space occupying effects and also local inflammation. And I love this picture. It's a, ultrasound image of an ovary with an endometrioma. And you can see like her poor little follicles are all squished on the outside. And you can sort of imagine that, especially in an IVF cycle, it might be harder for, all those follicles to grow. She does have one nice dominant follicle that seems like it's trying to grow. So hopefully for whoever this is her month. So in terms of describing endometriosis, I think we've all been traumatized by this point system at one point in our training or another that, that kind of traditionally we use a point system to describe how severe someone's endometriosis is based on what we see on laparoscopy. But like, I can safely say I've never actually like done this in clinical practice. Like I've never like assigned points to someone's endometriosis. I think what we do, which is much more helpful, is when we do surgery for these patients, we describe exactly what we see. We take representative images. But what I want to point out about this is there's kind of, I think of endometriosis, and a lot of people do, in two distinct categories where there's stage 1 to 2 or mild disease where, it's mostly superficial peritoneal disease. And then there's severe disease, and that's stage 3 to 4. And the hallmarks of severe disease are the presence of endometriomas, dense adhesions involving the adnexa, and cul-de-sac obliteration. So, when we talk through some of the literature, just keeping that in mind that like, those are the hallmarks of severe disease. And so that's some of the, characteristics that we study. So these are just some representative images of like mild or stage 1 to 2 endometriosis. I think we've all seen pelvises like this before, where like this looks pretty good, right? Like there's definitely endometriosis there, but the architecture of the pelvis looks largely preserved. So you don't really need to count up points to say this patient has, appears to have mild endometriosis with primarily superficial peritoneal disease. On the other hand, this is what we see more with severe endometriosis, that this image over here on the left is an obliterated cul-de-sac that, you've got bowels stuck to the back of the uterus, and that looks really not fun to dissect out, just looks really dense. And then over here, this patient looks like she has bilateral endometriomas that, you can actually even like, maybe it's just a shadow, but you can almost imagine, you can see the sort of chocolatey fluid under the surface. Looks like she's got adhesions in her cul-de-sac and then adhesions on both adnexa too. So I wanted to talk through a couple of cases, which these are cases that similar patients that I see every day, and I'm sure you see very, very frequently, because I think they help aid in our discussion about how to manage these folks. So this first case is a young 30-year-old woman. She's never been pregnant before, and she's been trying to get pregnant with her male partner for about a year without success. She's got regular 28-day cycles. She has evidence of ovulation, which is excellent. She has a history of severe dysmenorrhea when she was younger, and she was put on long-standing combination birth control. And that really helped her. When she came off, her periods are nowhere near as painful as they were when she was younger. Now she takes some ibuprofen and is able to get through her life during her period, no problem. She also does not endorse dyspareunia. And kind of because of this, she's been told, she may have endometriosis, but she's never actually had it. Never had a laparoscopy to confirm. And the rest of her workup is totally normal. So she's had normal ovarian reserve testing, a normal pelvic ultrasound. Both her tubes appear to be open on hysterosalpingogram, and her partner has a normal semen analysis. So aside from providing excellent preconception counseling for this young woman who wants to get pregnant, the question is, what do you do next? And options are, do nothing. Option 2, take her for surgery to try to diagnose and treat endometriosis if present. And then the other options are proceeding straight to fertility treatment, whether that's medicated IUI or IVF. And then choice E is a combo of doing surgery and then pursuing fertility treatments. And I think we can go ahead and throw out option A. I think this woman meets criteria for infertility. I think we should be offering her something. It's just a matter of what. So to address the question of, should we offer this young woman who may have mild endometriosis, but is not in a terrible amount of pain, should we offer her surgery for fertility benefit? And I'm going to try to convince you that we should not. So the literature suggests that surgery for stage 1 to 2 or mild endometriosis increases the probability of spontaneous conception a little bit. So there were 2 big randomized controlled trials in the 90s that compared diagnostic laparoscopy only to excision or ablation of endometriosis. And then they followed these women for 6 months to 2 years and assessed pregnancy rates. And they actually had opposing results. There was a subsequent meta-analysis that pooled these data, and they found an 8.6% difference between, diagnostic laparoscopy only and treatment of endometriosis in favor of surgery. And this figure here is kind of the forest plot of the pooled data. And you can see just barely statistically significant. So if you extrapolate this to a number to treat, this means you would need to do 12 laparoscopies in women with infertility and mild endometriosis to get 1 additional live birth. But we don't know, not all patients with infertility have endometriosis, right? So if we give a conservative guess that about 1/3 of women with infertility have endo, then you'd have to do 40 laparoscopies in these women to achieve 1 additional live birth. So, yes, is there possibly some mild benefit? Sure, but is it enough to warrant doing this many laparoscopies? And so, kind of to piggyback off that, diagnostic laparoscopy was once much more of a routine part of the infertility evaluation, and we really don't do that so much anymore. And that's because what we found in those studies that we just talked about, as well as several others, this was a part of the FAST trial, which came out of Dartmouth and Boston IVF. It is that if you treat people without the diagnostic laparoscopy, if you treat their infertility, most of them are going to get pregnant, and it was not super helpful. So in terms of, should we offer this woman fertility treatment instead of surgery as a next step, I wanted to talk through the various options. So medicated IUI does appear to increase the probability of conception in patients with endometriosis. And this is reported in several studies. Obviously, you're more likely to be successful with this if these patients have largely preserved pelvic architecture. And in randomized control trials, the pregnancy rates, these women act a lot like women with unexplained infertility in terms of the stats for pregnancy outcomes. So, there's about a 3 to 5% chance of spontaneous conception. But with treatment with medicated IUI, that gets bumped up to, up to closer to 15 to 20% per cycle. And if you get to try for multiple cycles, those odds stack up. There's insufficient evidence, though, to say whether doing surgery and then doing IUI is superior to just doing IUI. And I think without that evidence, again, that's putting a lot of people through surgery when we don't really know if it's helpful. In terms of IVF as a next option for the patient, IVF is an incredibly effective treatment for a number of infertility diagnoses, including endometriosis-related infertility. And per cycle definitely has the highest chance of success, but that doesn't necessarily mean it's the best first choice because, there's a lot involved in IVF. There's risks involved in IVF. Can be, exorbitant costs. And so just because it's something that works really well doesn't mean it's necessarily the best first choice for every patient. So for our lovely patient who we suspect maybe has mild endometriosis, otherwise unexplained infertility, and is not having severe pain symptoms, I put this in again that I'm trying to brainwash you to give excellent preconception counseling to all your patients who want to conceive. The question is, what are we going to offer her? And I would suggest we offer her a trial of medicated IUI. And the reason is, from the slides we just talked to that, I think this would be a reasonable first choice for her. We would expect it to improve her odds per cycle of trying. And if that's not successful, then we have other options that we could escalate to. And just as some little tips and tricks, for somebody like this in a medicated IUI cycle, I would absolutely use oral medications for her, not injectable medications. And some people, will preferentially use clomiphene citrate. Some people will preferentially use letrozole. Some people like letrozole better for these women because it keeps their estrogen levels lower. So something to consider. So for this patient, she tries medicated IUI 4 times. And from a cycle standpoint, that goes really well. The timing is right on, the sperm preps look great, but unfortunately she doesn't get pregnant. So the question is then, what are we going to offer her next? So options would be, do we try some more medicated IUI? Do we talk about IVF? Or do we offer her surgery at this point? Either, surgery and then continuing to try, or do we do surgery and then IVF? So in terms of the first question of, should we do surgery and then IVF? Basically, the literature out there does not suggest that doing surgery for mild endometriosis improves IVF outcomes. Before we talked about, does it improve the chance of spontaneous conception? But now we're focusing on IVF. So there was one retrospective study that did suggest a benefit to doing surgery for these patients before IVF, but a subsequent meta-analysis did not find a benefit in any of the outcomes studied, including live birth rate, clinical pregnancy rate, or number of eggs retrieved for these patients. And this is the forest plot from that meta-analysis for live birth rate. And you can see the pooled data circled in green. So our leading organizations do not recommend routinely performing surgery prior to IVF for women who have suspected mild endometriosis. So for this patient, that's we've got suspected mild endometriosis and has tried some medicated IUIs, I would suggest referring her for IVF as a next step. Again, in terms of further medicated IUIs, I think that's a little bit of a complicated question. I think for a long time, we felt like if someone tries medicated IUI 3 or 4 times and isn't successful, it might be time to consider moving on. There is a little bit of newer data that maybe longer trials are not unreasonable. But again, doing surgery or surgery before IVF is unlikely to benefit this patient from a fertility perspective. If she told you, I'm getting more and more uncomfortable, it's getting harder and harder for me to function because of endometriosis-related pain, that's a very separate question. And then in that case, surgery would be reasonable. So speaking of, this is a different case, is a 28-year-old G0 female. She's been trying to conceive with her male partner also for about a year without success. And she has a really similar story that she's got a history of painful periods and was put on birth control for a long time to help control that. But she's a little different in that since she stopped her birth control a year ago, her menses have become just more and more and more painful. It's getting harder for her to go to work and do things she enjoys because of pain. And now it's really hard for her to have sex because of pain too. Similarly, she seems to be cycling regularly. She seems to be ovulating. She's also been told she might have endometriosis, but has never had a laparoscopy to confirm. And her workup is a little different. She also has normal ovarian reserve. Her tubes both appear to be open, and her partner has had a normal semen analysis. But for this woman, you do an ultrasound, and she has what looks like a 4-centimeter right-sided endometrioma. And your whoever's scanning the patient, your sonographer or yourself, says they really feel like she might have a furthest, like things are not moving as they should. There's very limited mobility of her pelvic structures, and you're concerned she's got advanced stage endometriosis. So for this patient, kind of the same options. What are we going to offer her? Are we going to offer her expectant management? I would argue, there's 2 reasons we shouldn't do that. She has infertility. We should be offering her some sort of options for treatment. But also she's miserable. So we got to offer her something to, help with pain management too. In terms of medicated IUI, there's concern about her pelvic architecture. I think that's unlikely to be successful for her. So I think the question then comes down to, are we going to be recommending IVF for this patient, or are we going to be recommending surgery for this patient? So, wanted to go through in advanced stage disease, does doing surgery improve spontaneous conception rates, and kind of breaking that down into endometriomas versus cul-de-sac disease, because that's kind of how most of the studies are broken down. So removal of endometriomas does appear to increase the likelihood of spontaneous conception. So there was this observational study of women who had endometriomas and infertility that was otherwise unexplained. On average, the endometriomas were about 5 to 6 centimeters. And then they followed them for 8 years of trying to spontaneously conceive. And you can see there was a significant difference between groups. The women who had their endometrioma left alone only had about a 12% pregnancy rate over those 8 years, whereas the people who had surgery had about a 55% pregnancy rate over those 8 years. And the mean time to pregnancy was just shy of 1 year. Surgery for rectovaginal disease or cul-de-sac disease may also be beneficial. So for those women with infertility and cul-de-sac disease, spontaneous pregnancy rates post-op are, with pooled data, are estimated at about 24%. And you can see this figure here has the pooled studies that are out there answering this question, and they followed patients for variable amounts of time, but that 24% is presumably compared to 0% because these people had infertility before surgery. Interestingly, though, doing extensive surgery for this, meaning like a colorectal resection, doesn't actually appear to be superior to a more conservative approach of just dealing with the peritoneal disease. And obviously, there are more complications with more extensive surgery. So for our patient that has infertility, is really uncomfortable, and has suspected advanced stage endometriosis, this is somebody I'd offer surgery to. I mean, she's really miserable. Surgical options are one of the few fertility friendly options we have for pain management. But this is kind of a trick question, right? Because then after you do surgery, are you going to encourage her to continue trying her on her own, or are you going to offer her fertility treatment as well? And I think offering her treatment after surgery is not unreasonable, especially to shorten the amount of time to when she conceives, to minimize time that her endometriosis can progress. Yes, my little pop-up, kind of a trick question though. So in terms of surgical approach from a fertility perspective, for endometriomas, obviously trying to preserve adnexal structures whenever possible. So, rather than, this is obvious, but rather than removing ovaries with endometriomas, trying to perform cystectomies. Endometriomas are so hard to remove and can be just like so sticky and have a hard time, not causing any ovarian injury when you remove them. But when I've taken these out, I try to minimize my use of monopolar cautery, especially at the base, where the vessels retract and things are really oozy and you end up, burning and burning to try to get control. I usually use bipolar when I get down there. And I try to use blunt dissection, hydrodissection when I can to kind of minimize how much I'm burning ovarian tissue. And then for peritoneal disease, I know we've all got our unique way of how we tackle these cases, but and people feel really strongly about it. But really, in terms of from a fertility perspective, excision and ablation appear equivalent in terms of future pregnancy outcomes. So I'd say do what you are comfortable with, but also sometimes the lesion, lends itself to a certain approach. So like this top picture is, it's hard to tell from there, but multiple superficial implants, doesn't look like we're super near any critical structures. So that's someone I would probably ablate, just because it will be faster and this looks like pretty superficial widespread stuff. Whereas this bottom picture, I mean, that looks like deep endometriosis on top of the ureter. So I think it would be acceptable to leave that alone, because that you're at a high risk of ureteral injury. But if I was going to trying to go after this, I would probably, make a peritoneal incision adjacent and try to peel this away slowly and do an excision instead of ablating right on the ureter. So then, so for our patient that's got this pain and desires fertility, should we consider doing fertility preservation for her before she has surgery? And I think that's something we don't think about a ton, but it's something we should probably think about more. And there's definitely some women that would benefit from this before going to surgery. So I think some of the things to think about, I mean, it's certainly something you could talk to anybody about. But, especially people who are of more advanced reproductive age, people who are planning on delaying conception for a long time, people who have diminished ovarian reserve before they even start surgery, and then people who either have extensive surgery planned or have already had surgery or multiple surgeries before. It's something to think about talking to your patients about. And this is a nice little algorithm that I found that can aid in that decision-making process. So for our second patient, you perform a laparoscopic right ovarian cystectomy to remove her endometrioma. You perform an adhesiolysis and fulgurate all the endometriosis you see. You do a fabulous job. Pelvic anatomy looks totally normal after your procedure. And also you do a chromoperturbation at the time, and both tubes appear normal and open. And after the patient recovers, she feels so much better. She's so happy with her result, and she opts for a trial of expectant management before jumping into fertility treatment. But unfortunately, she comes back to you 6 months later. She's still not pregnant. Fortunately, her symptoms are pretty well controlled still. But you repeat an ultrasound and she's got a new endometrioma on the other side. And now she has on her HSG evidence of loculated spill on both of her tubes. And I'll kind of show you what I mean by that. So this is an image of a hysterosalpingogram, and you can see, the uterine cavity looks pretty normal. And the tubes actually look like they fill pretty normally. And they do both look like they spill into the pelvis. Like we're not seeing a dilated fallopian tube that looks closed off at the end. And if this was like your first or second image, you might not think anything of it because, the dye tends to hang out at the end of the fallopian tube in the earlier images. But if I told you this was your last image and you never saw the dye leave these spots around the tubes, you might wonder if there's adhesions now around the ends of the tubes that's blocking that contrast from flowing more freely. So for this patient now that has had a surgery, has a known advanced stage endometriosis, and now we think she's got tubal disease as well. What are we going to do for her? I think probably further attempts at trying on her own are not advisable, and neither would be IUI given the concern for tubal disease. So I think the question is, are we going to do another surgery for her? Are we going to do IVF for her? Or are we going to do surgery and then send her for IVF at this point? So in terms of the question of, do we do another surgery or do we do IVF? Generally, from a fertility perspective, IVF is superior to a repeat endometriosis surgery. So there's one retrospective study that looked at this. So women with advanced stage endometriosis who underwent IVF had a pregnancy rate of 70% after 2 cycles. And people who underwent a repeat surgery only had about a 24% probability of conception within 9 months of surgery. And so then the question of, do we do surgery to remove her new endometrioma and then do IVF? Removal of endometriomas before IVF hasn't been seen to improve outcomes. And that's been seen in meta-analyses of multiple individual studies. And actually, it seems like it can be harmful. Women who have their endometriomas removed before IVF have been seen to have lower antral follicle counts and need higher doses of gonadotropins during their cycles, which suggests, that ovarian injury has occurred. They also have been seen to have a higher rate of cycle cancellation due to poor response. And again, that all kind of ties into the loss of oocytes from surgical management. Really interestingly, though, there is one prospective study where they found that if you leave an endometrioma in place, you may get fewer eggs from that side. And you would think, okay, that makes sense. Maybe the person performing the egg retrieval wasn't able to get access to all the follicles because of the endometrioma. And when they parsed that out, that actually wasn't the whole picture. So we actually think that there can be compressive effects from the endometrioma, and you can have impaired follicle growth on that side too. So sometimes you will see a lower egg yield from the side with the endometrioma. That being said, you got to balance that right with risk of ovarian injury. So in terms of what do our leading organizations say about this question, and the short answer is, probably you should leave endometriomas alone before IVF. If they're large, if you're concerned that it's not an endometrioma and it's actually a malignancy, then yeah, surgery is reasonable. Very occasionally, I look at someone's ovaries and I say, oh man, I don't know how I'm going to get any of their follicles aspirated. So that would be a reason to do a surgery for them. So for Our Lady, I would suggest that at this point she be referred for IVF rather than doing another surgery when you just did a very extensive surgery for her 6 months ago. So for this patient, she has an uncomplicated IVF cycle. She gets pregnant. She returns to you for prenatal care. She is a magical obstetric unicorn that uncomplicated pregnancy, term vaginal birth. She's put on continuous birth control in the postpartum period to help control her endometriosis and provide contraception, because infertility is not birth control, as I think many of us have learned from our patients over the years. And I wish all of their cycles went this way, but she has 4 additional really nice blastocysts cryopreserved, and those are waiting for her when she's ready for baby number 2, if that time comes. So just a little bit about resources for these type of patients. New Hampshire is wonderful in that it's a mandated coverage state for fertility services. Most of the patients that I see are aware that they have coverage and what they have coverage for, but I've had a couple of patients who are shocked to learn that they have coverage for IVF and other fertility treatments. It is by no means a perfect system, and there's some people that kind of fall through the cracks and don't have coverage for treatment. Plus, access is a challenge, right? Like even if someone has coverage, we don't have that many fertility clinics in our state. And unfortunately, for those of us who practice closer to Vermont and take care of patients from Vermont, the vast majority of Vermont patients do not have coverage for IVF. But that being said, there are fertility grants out there, there's fertility loans out there. And so just because somebody doesn't have coverage doesn't mean these options shouldn't be explored for them, because usually we can find a way to help. And then in terms of resources for these patients, there's this great organization called All Paths Family Building that I really like. And what I like about it is they have free virtual peer support groups, and the peer support groups are very specific. So, it's not a generic infertility support group. I'd have to double check, but I think there is like a endometriosis and infertility group that people can join in on. They also have a great resource library, insurance assistance, and they do a lot of advocacy too, which is wonderful. I also have a lot of patients who are very sheepish about telling me that they listen to fertility podcasts and social media accounts and things like that. But I think those things can be wonderful. And as long as the information is good, I encourage people to go down those avenues. And then both for patients and for providers, there's so much good support and information from national organizations like ASRM. Some of the less known ones are like Society for Reproductive Endocrinology and Infertility and Society of Reproductive Surgeons. For Society of Reproductive Surgeons, they have this really fabulous free lecture series that's like for fellows, but they have like great surgical videos as part of that. And I've watched a lot of those and really enjoyed them. So just in summary of the things we covered, so surgery for mild endometriosis may have a small benefit for increasing likelihood of spontaneous conception and improving IVF outcomes, but not so much that routine performance is recommended. surgery for advanced stage endometriosis may increase spontaneous pregnancy rates, but specifically in patients with rectovaginal disease, it does not appear that more extensive surgery is beneficial beyond removal of superficial or perineal disease. And I want to be clear, that's for fertility benefit, that's not for pain management. Removal of endometriomas before IVF does not appear to improve pregnancy rates, but may be considered to improve access to the ovaries. And then egg freezing should be considered prior to endometriosis surgery if the patient's considering delaying conception, especially if she is of advanced reproductive age and either has extensive surgery planned or has had extensive surgery in the past. And then I would throw in there too, if she's got diminished ovarian reserve. So I've got a list of references, and then I'm gonna stop sharing so that we can go through any questions that anyone has. But thank you so much for your time and for asking me to talk about this.
Thank you so much, Dr. Nesbit. That was fantastic. We do have some questions.
Okay.
The first one is there still a place for empiric medication treatment of endometriosis for 6 months if patient's young enough?
Oh, so I would assume that means before, before pursuing fertility treatments. That's what I would assume that question means is, so if
Yeah,
somebody,
if they're
yeah.
young enough, yeah, yeah.
I would probably proceed right to treatment for that individual. I mean, I think the role for medical management is really in people who aren't ready to get pregnant yet and trying to prevent progression and control symptoms before they start wanting to try. But usually I'm not recommending medical management that would delay their fertility care.
Great. Do you find that earlier referral for IVF improves outcomes in these patients with endometriosis, or do you typically try other treatments first?
I mean, I'm happy to see anyone anytime. Like, I feel like there's not a lot lost by having those conversations earlier and offering the patient options. I mean, I try to be really frank with people about what I think is going to work for them and what isn't. And somebody with that you think has mild disease, if any, and it is not having terrible pain, like absolutely, I think they'd be a candidate for less invasive treatments. But I think there's a balance too of trying to minimize the time the patient is off medical therapy for endometriosis. And so some women will say, like, look, I get it. I'm a candidate for less invasive things, but I want to minimize the time off of my birth control or LISA or whatever it is. And so I'd like to pursue IVF to minimize the amount of time I'm off of those therapies and before I get pregnant.
Great, thank you. I have one more question here. How do you usually manage fertility in patients with endometriosis, particularly when ovarian reserve might also be an issue?
I think it really depends on the individual patient and what other symptoms they have and what our best understanding of their disease is like. So if someone has, I suspect, mild disease and their symptoms are manageable, then I honestly treat them kind of like an unexplained infertility patient where I offer them medicated IUI versus IVF, and have a discussion about the pros and cons of each. If somebody has, evidence of severe disease, then I am much quicker to recommend IVF for them, and I kind of reserve surgery for if they're really uncomfortable or if I really think I'm not going to be able to access their ovaries with IVF. So that's like generally how I would approach people. But your point is a good one about ovarian reserve. And I think, if somebody wants a large family, you got to kind of take their long-term family building goals and their age and the endometriosis all under consideration when you're recommending treatment for them. So for example, if I, if I have somebody with diminished ovarian reserve who's who wants a large family, like maybe they'd be a candidate for IUI, but I'm thinking about their second and third baby. Even though we might be able to get them pregnant with one baby, no problem. I'm worried about 2, 3 years down the line when we're trying for the second baby. So sometimes that plays into the decision making.
Great. Well, that's all the questions for today. Thank you so much, Dr. Nesbit, and thank you everyone for attending today's webinar. If you have any other questions, please contact Alyssa Cooper at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view today's recording. On behalf of Boston IVF and Carleigh Nesbit, thank you for joining us today and enjoy the rest of your day. Thank you.
Thank you so much.